Welcome to Clinical Minute. Joanna, who is 55 years old, comes to you asking for a checkup because she is experiencing some mild irritation down there. She is reluctant to provide you with additional details and looks away, embarrassed. You ask her some specific questions, which reveal that she has no vaginal discharge, but she does have a history of vaginal dryness for 3 years that started soon after her last menstrual period. You ask about her libido, and she replies, "Sex? Well, I'm not that into it lately." When you ask if intercourse is painful, she admits that she has been experiencing pain during intercourse for the last year or so. She has no new sexual partners, and she has some very mild urinary symptoms, with increased frequency of voiding and mild stress incontinence when she coughs. Those symptoms started about 6 months ago, she thinks. You consider a possible diagnosis of vulvovaginal atrophy. You explain to Joanna that she may be experiencing some changes that occur in the vagina after menopause, a very common postmenopausal issue that can be easily diagnosed and treated. You also explain that these changes are a very natural outcome of menopause, and that they are sometimes called vulvovaginal atrophy. You let her know that you don't particularly like using that medical term for these natural changes, since it can imply something abnormal is occurring. However, you want her to be familiar with the name if she hears it again or sees it on a medication. You tell Joanna that vaginal estrogen decreases over time, and vaginal tissues thin and become less elastic as she gets older. As a result of this, natural lubrication is reduced and delayed, and sex often becomes uncomfortable or even painful. These factors may negatively influence sexual motivation, activity, and the woman's relationship with her partner. Urinary symptoms such as painful urination or stress incontinence, risk of pelvic organ prolapse, and painful urination may occur too. You complete a physical exam for Joanna, which reveals pale, dry skin, thin, friable epithelium, atrophy, thinning, and decreased elasticity of vaginal walls, vaginal dryness, and elevated vaginal pH greater than 4.6. You explain to Joanna that you are considering 2 diagnoses. The most likely one is postmenopausal vaginal changes due to low estrogen, what is typically called vaginal atrophy. But you will also evaluate for a vaginal infection just to make sure the symptoms are not caused or exacerbated by a urinary tract infection, vaginitis, or a sexually transmitted infection. You remind Joanna that her previous lab results indicated her hormones are normal for a postmenopausal woman. You tell her that changes due to low vaginal estrogen are perfectly normal in postmenopausal women and that you are glad she came in for an appointment to see you. You explain further that if this is the source of the symptoms she is experiencing, then you can offer her some options for treatment. These benefits include vaginal moisturizers and/or local estrogen treatments that may improve sexual desire, arousal, and orgasmic function by increasing blood flow to the urogenital region and by increasing vaginal lubrication and oxygen levels. You then review today's test results for Joanna, which reveal negative urinalysis, UA, negative wet mount, negative chlamydia trachomatis Neisseria gonorrhea, CTGC. You explain to Joanna that her lab results show no sign of infection, and you believe that her symptoms are due to reduced vaginal estrogen, vaginal atrophy. This would explain the irritation, as well as the urinary symptoms and decreased libido. Joanna wants more information on how low estrogen can cause these changes, so you explain a little further. The drop in estrogen that occurs during menopause causes the lining of the vaginal walls to get thinner. Fewer cells are now shed from the vaginal walls, and that changes the activity of the healthy bacteria that are found in the vagina. The net effect is that the acid-base balance changes, and the pH increases slightly. You tell Joanna that the potential treatment options for vulvovaginal atrophy include non-hormonal options, including over-the-counter vaginal moisturizers and lubricants, as well as the option for prescription vaginal estrogen. She asks about the difference between a lubricant and a moisturizer. Vaginal moisturizers, which come as gels or creams, are different than simple lubricants, you tell Joanna. These are used for a longer period of time to replace normal vaginal secretions. Moisturizers have been shown to improve itching, soreness, irritation, and painful urination within the first week of use. However, you first acknowledge that Joanna may be uncomfortable with inserting something into her vagina, so you use a pelvic model to explain insertion and observe any hesitation towards using a vaginal insert therapy. Joanna seems fine with vaginal insertion and asks how often she should use a moisturizer. You reply that she should insert it regularly into her vagina 1 or more times per week, not just during sexual activity. This consistent use will help maintain the hydration of the cells that line her vagina and provide the long-term relief of vaginal dryness. You further explain that moisturizers do not change the amount of estrogen in the vaginal cells, so they can't reverse the physical changes in the vagina that occur after menopause. You tell Joanna that if she uses a vaginal moisturizer on a regular basis, she may find that her symptoms are improved as much as if she had used a topical vaginal estrogen. Joanna is interested and asks about what kinds of moisturizers are available. You give her some examples. Replens, Summer's Eve Moisturizer, KY Silk E or Liquid Beads, Vagisil Feminine Moisturizer, etc. She asks if any of the ingredients are bad for you, and you explain that while you don't know if parabens would cause any problems for her, some patients do try to avoid applying these chemicals to the vagina just the way they avoid them in sunscreens. Blossom Organics is one example of a paraben-free vaginal moisturizer available in some of the major drugstore chains. You also explain that vaginal lubricants temporarily moisturize the vaginal epithelium to facilitate intercourse, masturbation, or use of sex toys. You tell Joanna that she may wish to use a lubricant to reduce friction during intercourse. These include water-based and silicone-based versions that work equally well for these symptoms. Common types include water-based lubricants, KY Jelly, Liquid Silk, Astroglide, Slippery Stuff, and silicone-based, ID Millennium, and Pink. You start to explain that she should not, however, use oil-based and petroleum-based lubricants. Joanna looks confused and interrupts, saying, "But I thought they only affected latex condoms, and my partner and I no longer use condoms now that I'm past menopause." You explain that oil-based lubricants do degrade latex, but are also difficult for the vagina to clear and may predispose to infection. You continue explaining that in addition to using a moisturizer and a lubricant as needed, her symptoms may also be eased with increased frequency of sexual activity, as long as she avoids intercourse while she is experiencing inflammation. You also ask if she has started smoking again. She replies that she had smoked as a teenager, but had stopped in her early 20s. You tell her that smoking is bad for vaginal health, too, and she replies that she has no intention of starting again, but that it's good to know this information. It gives her even more reason not to start again, she says. You continue explaining her treatment options, turning to local vaginal estrogen. You explain to Joanna that local estrogen therapy is effective for women whose symptoms, like hers, involve vaginal dryness or discomfort with intercourse or mild urinary discomfort. You tell her you would recommend low-dose vaginal estrogen therapy if she chooses this option. You explain that local estrogen therapies include creams, tablets, and vaginal rings, and show her this table. You point out that vaginal estrogen replaces the estrogen that is no longer present in her vaginal cells and reverses all of the effects of low estrogen in the vagina. Vaginal estrogen should ease most of her symptoms, but should ideally be used for as much time as needed. Joanna asks how safe vaginal estrogens are, since she has heard that estrogen is bad for you after menopause. You clarify for her that these small doses of vaginal estrogen are considered safer than oral medication as they result in much lower blood levels of estrogen. The estrogen will act directly on the vaginal tissue. A 2010 Cochrane review of 19 trials, 4,162 women, showed vaginal estrogen use is not associated with endometrial hyperplasia or incidence of proliferative endometrium 9 when compared to placebo preparations. You also explained to Joanna that if she chooses vaginal estrogen as an option, she should use the smallest effective dose for the shortest effective time, and that you will help her to reevaluate her need for treatment periodically. She should definitely return for a check if she experiences any postmenopausal bleeding while using the vaginal estrogen. Joanna decides to try a vaginal estrogen tablet. You prescribe this, explaining that she should insert 1 tablet each day for 14 days, then 1 tablet twice a week as a longer-term maintenance dose while she needs it. You tell her that she should notice improvement in symptoms over the next month or 2. You arrange for a follow-up call or visit in 2 to 3 months. You also remind her to return sooner if she notices any bleeding.